All right. Good morning, everyone. It's Lisa. I think we'll go ahead and get started with grand rounds. It's easy to be really prompt when we're virtual. Uh, we're going to spend some time this morning giving some additional updates about our response to coronavirus within the department. So we're going to start off having Dr. Neglia share a few words, and then I'll orient everyone to who you can plan to hear from today. Please keep yourself muted if you are not talking. You can choose to show your face if you want to. You don't have to. We'll use the chat window as a place for people to ask questions if you have them, and we'll also have some open time where you can just unmute yourself and ask questions the old-fashioned way as well. So Dr. Neglia?
So thanks, Emily. Thank you all for joining in on our second week of virtual grand rounds. The grand rounds today is really an effort to keep people as updated as possible. There is a lot of information coming out continually, and that information seems like it changes every 24 hours, and that's because it does. There really is a lot of work going on to react in real time to our issues around the university policies, around personal protective equipment, the clinical states of the program. So things do change, and that's why it's important to keep up. You're going to hear from a whole lot of people, and there are a whole lot of people in the department that are doing a ton of work right now to make this all happen as smoothly as possible. From the education side, research and clinical side, I can't say enough of the people you're going to hear from, but really everybody who's stepping up and going above and beyond. It's an extremely busy time. You probably saw that the university president has announced that we're in a time of extended reduced operations. The university is not closed. However, we need to expect a very reduced level of operations for quite some time. One of the things that means is that we are going to have to identify essential employees. All the clinicians are going to be designated as essential employees, but you will actually be receiving if you've been designated an essential employee, you will be receiving a document via email that I believe you're going to be asked to keep with you if you are on the campus. So you will need that, and you will need your IDs on the campus. Other things that you probably saw is the travel restrictions have been extended now through the end of May. There is universal masking that is starting to take place, is rolling out in a few selected spots right now, and I would think others will have more to say on that. The dress code has been relaxed. Now for pediatricians, that's usually not that big a deal because they tend to be a little less formal than others, but no ties, no white coats. They want you to wear clothes that can go in the laundry and be washed with hot water or reasonably hot water. And then the other thing that we are trying to get a handle on right now is a hiring pause from the university and from UNP, and trying to understand where in the hiring process that actually kicks in. We have people with offers that they are considering right now. We have people that have been here for 2 interviews and have been negotiating back and forth. Certainly anybody that has a signed letter, in receipt of the signed offer letter has the opportunity to sign that letter, and anybody that we have hired, we will do our best to honor their start date. But the president is asking that there be no new hires and that start dates be pushed back if possible. So hopefully we will have more guidance on that over the course of the next 24 or 48 hours. The last thing I just wanted to ask people in the divisions for patients is to consider some kind of shift work, ways of maybe bringing one person in to handle the kids that actually need to be seen in clinic rather than bringing 4 people in to each see 2 patients. Trying to reduce people's exposure to reduce the likelihood of everybody getting sick at the same time. The expected numbers in the population still keep saying 40 to 80% of us are going to get it. We just don't need all 50% of us to go down in the same week. So that would be be hard. So there'll be time for questions as this moves along, but I'm going to, again, thank everyone and turn this back to Dr. Borman-Shoap.
All right, thanks very much, Joe. Let me just get, I've got a not overly fancy presentation, but just something to kind of keep us oriented as we go along. So what you can, hold on a second. If my Google Slides will cooperate, hold on, there we go. So I've asked a few people to come in, just kind of share some insights. So Sam Gupta is just going to give sort of a high level about, you know, what is the command center, who's working together. I think some people may be curious about that. Brandon Nathan's going to give some updates on outpatient process. I know there's been a lot of changes there. Angela Panaskaltis-Mortari is going to just recap some of the research impact that we talked a little bit about in the faculty meeting. Betsy Murray is going to talk about medical students and how they've been impacted. And then Beth Swanson and I will talk about what to do if a trainee or employee is sick. And I think she's also got some updates about the universal masking that Dr. Neglia alluded to. All right, so Sam, I know you've got a bunch of other stuff going on this morning, but if you want to just maybe take a couple of minutes to update the PEDS faculty about the kinds of things you've been talking about and working on, that would be great.
Sam, you're still muted.
Can you hear me now?
Yep, we got you.
Okay, thank you. Sorry about that. I just wanted to echo again what Joe said, you know, just thanks to everyone. A lot of people have put in a tremendous amount of work, either in prepping, planning, helping make decisions. You know, it's been impressive to see in this kind of stressful time, people come together to work together, a lot of grace, a lot of cooperation, collaboration. And so it's been fantastic to see, and we're gonna need more of it for sure. So Emily wanted me to talk just briefly about kind of the command center structure and how it works. So we have what's called a system incident command that's located at Midway for the system as a whole. The leaders are Linda Wick, Greg Dielman, and Jeff Dichter. So 3 individuals from UMMC. They are sitting there leading our incident command center. And they're partnering with all sorts of individuals from the system, whether it be supply chain, pharmacy, respiratory care, outpatient or ambulatory. And they've really, in a short period of time, accomplished a lot. If you look at the number of virtual visits we're doing from an outpatient standpoint, you know, I think the 70% of our visits are virtual at this point in time, to bringing up a COVID hospital at Bethesda in the matter of a couple of weeks that should open hopefully Thursday or Friday this week to take all our COVID positive adult patients, but COVID positive patients, at least for the time being. And so the way the command center works is they look at the work that needs to be done, create work groups to perform the work, get reported out. So they're kind of overall overseeing everything that we need to be doing. And there's a lot to be done, you know, whether it be just making sure that we have our supply chain in order, or working with our research and education, you know, looking at leveraging the medical students who've been amazing in offering their services, both for on-care as well as for babysitting services. They try to organize all that work, as well as ensure that things are happening at the ground level at each individual hospital. And so at UMMC, we also have a incident command center so that we can take the work from the system and then operationalize it, because these ideas are great ideas, but then they need to kind of hit the ground and make sure that they are functional, whether it be our visitor restrictions, which we changed like 3 times in the matter of like 3 or 4 days. But again, as Joe mentioned, things are changing dramatically and quickly, and we need to be extremely nimble. This is going to teach us a lot, actually, as an organization, of how we can change quickly with when things are happening. I think there's a lot of good things that will come from this. I mean, telemedicine being a huge aspect that we've developed kind of overnight, as well as our ability to react as an organization to changes in either the marketplace, clinically, or whatever it is. Was there anything else, Emily, that you thought would be important for me to share?
I think that's mostly just people had probably curiosity about sort of the central command center and then how things get brought out, and then probably any advice you have about the best way to bring ideas or questions forward, because there are so many different working groups. It sounds like trying to not flood just one individual's in basket. If there's guidance about types of questions that should be sent in certain direct.
Sure. So I think the best way to do it is we have an email for the UMMC Command Center. If you have questions, you can either call the number for the Command Center during the day or email the Command Center. I don't remember the email off the top of my head, but I can definitely share it with Emily later to distribute out. Probably be the best way to do it. Then we have individuals there. We always have infection prevention sitting there. We've got an operational leader. They've got access to me whenever they need it, as well as people from emergency management and some other specialists there. And so there's a group of individuals who can oftentimes answer questions quickly, and if they can't, they'll raise them up as necessary. And then we've got a cadence of kind of calls throughout the day. And so we meet as an acute ops for the whole system every day between 10 and 11:30, where we can bring up all our issues, questions, concerns that we have at the site level. And that's oftentimes what leads to changes in the system email that comes out later that evening. And then there's a system command center call where they report out all the work they've done for the day and kind of where the progress is and what they're doing for the following day as well. So there's a number of way information gets routed up, and then they try to bring people together to try to make the best decision they can. And that's where I'd say, having a little grace for the system command center would be important. They're doing the best they can in a situation that has a lot of uncertainty and ambiguity. And so obviously I think the biggest thing that we were concerned about is the well-being of our staff and employees and faculty. I think that's where the biggest concern and stress is across the medical center as I walk around on all the different units. That's the biggest question. Am I safe? Am I protected? What's the right PPE? And so I think the universal masking, which we're going to get to over time, we have to watch our supply chain very carefully as we do that, will be a huge step in making our staff and faculty feel more protected. It's really hard to work efficiently and effectively when you have fear of your own safety. So I really think that has to be our number one priority as we move forward as a system. And the command center's heard that loud and clear, and is trying to do as much as they can. And the university is actually being a big help, with their engineering department creating face shields and N95s for us as well. So hopefully our supply chain will be fixed, but there's no guarantees around that either, because everyone in the country is in the same boat. The other thing I'll say is the command center is acutely tied into what's happening on the coast in Seattle and New York. And the goal is to learn from the mistakes that they've made so we don't make the same mistakes. And so we are trying to make sure we're ahead of the curve as much as possible, knowing that there'll be still some mistakes that we're going to make as well as we go through this.
Thanks, that was really helpful. Could you just let us know who is representing pediatric and maternal health at the command center? You're there, it sounds like.
And so at the System Command Center, it's Dan Landers and Sarah Jane typically call into the System Command Center. I don't know if they're sitting with the Command Center at Midway, but they definitely call in to the calls as well. And then I'm still representing Masonic through UMMC.
Great, thanks, that's really helpful. There was a specific question from Cliff about restriction of specific medications for clinical trials that I'm guessing you may not have an answer to, but we can work on getting an answer to that one and feeding it back to the department, unless you have an answer at top of mind.
Are we specifically talking about like losartan, hydroxychloroquine, and the medications for COVID, or other research medications?
Azithromycin.
Sorry. I could answer that.
Yeah, go ahead, Cliff.
So the update that came out last night indicated that providers should not prescribe antivirals or other specific therapeutic agents like azithromycin and hydroxychloroquine unless it's in the context of a clinical trial. And to my knowledge, there are no clinical trials currently that include pediatric age patients. Our
Correct.
group, our abdominal SOT group put together a plan with Shane McAllister over the weekend and early this week that discussed, the use of additional therapies in immunocompromised children who are, with impending respiratory failure.
So Cliff, I've actually seen that protocol actually. I know Shane's working on it, and Beth Swanson actually can speak more about it. We've raised it up to the system level because we do think pediatrics is different, and that we want to be able to prescribe these medications as we need to, as we feel like we have a clinical indication for. So that's the approval we're looking for. Beth's actually taking the lead on that, so she can probably say a little bit more about where that is. But I know she's trying to build a care path through IT for that purpose right now. And we will advocate strongly that PEDS is not restricted in the same way the adults are.
The leadership had a conversation about this yesterday, and it was indicated that pediatrics was excluded because specifically they were excluded from the clinical trials. So they were not in the compassionate use restriction group that the adult patients were.
Correct, we shouldn't be. We should be able to utilize it differently. And it's been used in other institutions as well already in pediatric patients.
Okay, great. That sounds like that's something that will be ongoing discussion on those lines.
Hi, this is Beth Swanson. I'll be addressing this with the system command today. I'll see if we can get different messaging out for the pediatric population.
Thanks, Beth.
Great, thank you.
Okay, are there other questions for Sam? I think he's got a call that he needs to get to, but if there are more, we'll definitely get the command center email and phone sent out with the notes from today's call. And I think next we'll turn it over to Angela Paniskaltis-Mortari to talk a little bit about impacts on research.
Thank you, Emily. So first, let's talk a little bit about the clinical research. There's been impacts everywhere. So almost all non-COVID-19 research has to be suspended, although you should check with Amanda or your clinical trials office if you have a trial with active participants that are receiving therapy. The research has all been categorized into tiers, and most of our trials fall into tiers 2 or 3, and a lot of 4s too. They all require a submission to the IRB. And for a lot of these, the requests now are going through REDCap. If you have a tier 1, that's a COVID-19 protocol. Those, of course, are being expedited by the IRB. If you have a new idea, there's a form there, the link to the form to complete. For tier 2, that's for high direct benefit to participants, or if the research is stopped that could cause harm. That requires submission to the IRB with an explanation, and that's not optional. Of course, it requires a safe plan, no new recruitment and accrual. If there are some exceptions, they have to be approved, and there's the link to fill out yet another REDCap form. Tier 3, moderate direct benefit, that could continue if the PI determines that the research could be done in a safe manner that minimizes contact, mostly if it could be done remotely. Immediately pause new enrollment. Approval is required to continue any in-person work, and you have to submit that request by Friday. And there's the link to the form there, REDCap form. Tier 4 is low direct benefit to research participants. If you cannot do this research remotely, then you have to stop it at this time. Tier 5 is the IRB exempt type of trials. If you can't do that remotely, that must also stop at this time. And importantly, please document the impact on your study, so when it comes time to do your progress report, you have all this information. Now, there is now some effort to try to streamline all this, so developing an upload template so that all the requests can be submitted. Next slide, please. So if you have any questions, please contact Amanda Galster. And there's also updates that are constantly being put into this shared Google Drive here, and there's the link to that. That's updated almost daily. And also for other things, you can check the OVPR website, and there's the link to that. Next slide, please. And now for those of us who do non-clinical lab research, we've all submitted essential minimal operations plans. And basically a lot of research efforts have been put on pause. Anyone doing computational work that can be done at home, lots of people are working at home. So all non-COVID-19 related research has to be paused, but there are some exceptions. You can finish current ongoing experiments if it would be really too expensive to do later, although they're starting to restrict that as well. So for example, the VP for research has said that, you know, they're not worried about a $1,000 cell culture, whereas they are worried about, for example, a large Tesla magnet that would need to be turned off and back on that would cost like $1 million. So it has to be something really substantial, or time sensitive. Like you already have, you know, mice that have been transplanted and ongoing, and, you know, it just needs a little bit more time to finish. Or you have samples that just need to get processed right away or they'd be ruined. If you're breeding non-commercially available mice, just maintain the amount of breeding that is needed to maintain the strain. Anything that's commercially available should be culled and euthanized. So the ultimate goal is to minimize the personnel numbers in the lab. Hopefully try to have only one at any one time in your lab and stagger the working hours. Most people should be working from home at this point. And of course, anyone who is designated an essential person will be receiving the designation notice, and they need to have it with them. And so it's important for everybody to have updated their essential minimal operations plans. If things have changed since the last time you submitted them, like a week or 10 days ago, please let me know. I've been asking everyone to update it, and just to make sure that we have everything accurate, because a lot of the postdocs and grad students don't actually show up on HR because they're not all considered U employees, because they might have NIH fellowships, for example, or on special types of training grants. So it's really important for us to know everyone who is going to be on campus. Don't forget to communicate with all your trainees. Next slide, please. And we will have virtual press. So we will be doing, allowing or not allowing, but we're excited to be able to listen to all the presentations of all the great research that all the trainees have been doing. We're going to have it on the same day. It's going to be done through a series of simultaneous Zoom meetings. So you'll be able to go in and out of the different ones. You can see as many of the presentations as possible. So basically the time format will be the same as if it were done in person. So we'll have the top 8 abstracts that were submitted, and we did have 90 abstracts submitted. So tremendous job, everyone. So the top 8 will be oral presentations, and everyone will have access to see those. And we're trying to work out how to get everyone to submit the audience score for those. And then we'll have the poster sessions, and for those you'll be able to go in and out. The only people that have to be always on their designated Zoom meeting would be the judges that are designated for 5 poster presenters. So those will be always in a Zoom meeting, whereas everybody else would be able to go in and out. And we'll have virtual awards for the oral presentations at the end of that day. And the poster presentation awards will be announced the following Monday. So make sure everyone has access to Zoom. And we really look forward to seeing all the great research that all the trainees have been doing. And I'm sure everybody's going to welcome something that's non-COVID related. Thanks, everyone. Oh, I think that there might be a couple questions here.
Amanda's going to follow up with the questions, and the number of COVID cases is maybe a question for Beth for later.
Bryce is asking when abstract acceptances will be announced. Yes, we're doing that this week. Of course, they are all accepted.
The posters are going to be digital.
They will be digital, yes.
This is really very environmentally friendly, all the things that we're doing now.
Yes, it is.
Less printing.
Yes, it is.
Wally is asking about for database research, and I don't know if anybody's going to talk about it, but bandwidth to access Epic has been increased dramatically over the last week. So Waleed, I would think if somebody's doing research that involves the secure gateway, that theoretically could continue unless we start to have trouble with the secure gateway things going down.
All right, so it looks like most of the research questions have been answered, and Amanda Gulster or Angela are certainly great resources there. We'll move on to our next section here. So I hope that you have all started to think a little bit about the fact that our medical students have been hugely impacted by these changes. And I just wanted to ask Betsy Murray, our medical student clerkship director, to give you a little overview into sort of what that means and help us start to think ahead about what the upcoming months might hold.
Good morning, everybody. This first slide is just to help orient you to the third year for the medical students, which is the year that's being the most significantly affected right now. This is the third year in table form. Each column is called a lane. Each lane contains about 1/10 of the class, or 20 students. As each student descends through a lane, they complete all of their third year required clerkships. They just complete them in different orders depending on the lane. This design guarantees that all third year students get the same clinical immersion experiences during their third year. Next slide. Due to COVID-19, the students stopped direct patient contact on March 16th and were moved to a distance learning curriculum that will continue at least through May 13th. As you can see, the lanes were effectively interrupted in March, and that interruption is expected to continue into the next academic year, which starts on May 4th. The red arrow signifies the timing of the interruption of direct patient care for the rising fourth years. The blue arrow signifies the interruption in direct patient care for the rising third years. Next slide. As you can imagine, just this 2-month interruption creates a significant challenge for the medical school in its traditional curriculum design. Of course, an additional challenge is that no one knows exactly how long the distance learning will extend. Uncertainty about COVID-19 directly affects our certainty about when students will return to direct patient care. At this point, 2 classes of medical students will be directly affected by this interruption on their clinical training. They will also start to pile up on top after the usual curriculum resumes. This creates a traffic jam of students waiting to complete their clinical training with direct patient care. Next slide. So who directs this traffic? This is the team of people who are working feverishly on this problem right now. Please note there's student representation and input throughout this process. The Assistant Dean of Curriculum and her staff in the Office of Medical Education are working hard on design options for restructuring the curriculum. The Associate Dean of Undergraduate Medical Education is overseeing all this work in concert with work in other offices in medical education. The restructuring options will be reviewed and endorsed by faculty clinical education committees, consisting primarily of clerkship directors from the various required clerkships. Education Council is the faculty committee that will render the final decision regarding the curriculum design, and this decision will have to be approved by the dean. Next slide. So, what should we be doing and what should we be planning to do? First, we have to clear out the traffic in front of the traffic jam. Current fourth years will all graduate on time as planned and move into their residency positions in July. That has already been permitted by Ed Council, and they will move forward without interruption. The next thing we can do is add horsepower and aerodynamic design to the cars that are in the jam so that when they get out of the jam, they can move more quickly. Current third years and rising third years have started and will start a distance learning curriculum to complete all the clerkship requirements that do not include direct patient contact. These curricula include all the required readings, all the required online cases, sessions like morning report and this grand rounds have been moved online. And students, and I know there are students with us here today from the pediatrics clerkship, they can join us remotely. When possible, additional sessions have been added to simulate random care. Students will take their final exam in pediatrics remotely with distance proctoring using Zoom. Outside of the clerkship, students are also able to do distance learning clinical electives to obtain elective credit. We hope this preparation and completion of required curricula will allow the students to move more quickly through the direct patient care portion of their clinical immersion training. You can also increase the number of lanes that exist after the traffic jam. So once the traffic jam starts breaking up, we'll need as many lanes as possible to move everyone through in the original time frame. And this affects our faculty probably most directly, because this means expanding clinical capacity as much as possible. In the coming weeks, we'll be exploring creative ways to expand clinical capacity in the medical student courses in pediatrics, and anything anybody can do to support this process and expand capacity for medical students would be very much appreciated. Another thing we can start doing with the traffic jam is we can start moving as many cars through the traffic jam as possible. One plea I would make to anybody out there who can influence these decisions is to consider integrating students into telehealth as soon as it's adopted, or at least begin to make preparations to include them in telehealth as soon as you can. Anything you can do to support student integration into telehealth will be helpful, because it will allow us to re-engage them in direct patient care as early as possible. And then one of the most innovative plans, and I'm not sure how much traction this is going to get, is to think about building an express lane. Nearly 50% of our graduates stay in Minnesota for residency training. And I think we have to start thinking about, is there a way to collaborate with these residency training programs to prepare for time variable entry for students who demonstrate that they can move through clinical immersion training more quickly? This is going to be particularly important if distance learning persists through the summer and into the fall. If this sounds familiar to any of you, it is a lot like the EPAC program. And if distance learning continues, I think we do have to consider that. Thank you, and I'll be happy to take your questions.
Not seeing a lot of questions on the chat so far, but just really wanted Betsy to give you all some line of sight into the kinds of conversations that are happening at the medical school, and to really have us all thinking in the next 2 to 3 weeks as we get into a little bit of a rhythm, how could we re-engage students in the work that we're doing? I think we've been quite well positioned in the medical school with a wonderful catalog of pediatric electives that our students have really enjoyed taking. And I think there may be some opportunities for us down the road to be pioneers in education, just like we have been with the EPAC program. So just be thinking about our students and how they could be a part of things going forward. Bryce is asking about the bandwidth. I'm not sure about that. I know they've been having some of the people who are doing on care and other things actually physically come to places that are hardwired, where you can still sit with appropriate physical distance from one another to prevent risk. So that's something we have to look into a little bit.
Yeah, that's something that seems to be loosening up quite a bit, Bryce. So it may be okay. Brandon may have some insight into this too, as it involves telehealth. So that would be good to understand.
Yeah, great. All right, Brandon, you're up.
Great. So good morning, everyone. Emily, thank you for giving me a few minutes here to talk about some updates to the ambulatory workflow and ambulatory care that you all have been helping roll out. So I thought what I would do in the few minutes that I have this morning was to kind of review the steps that we've taken as a department and as a system, which I think actually highlights how impressive our efforts have been in dealing with this crisis. And it also gives us an opportunity to review just a few of the things that we all should be doing. And then lastly, we'll just take a quick look at what to be expecting, what you all should be expecting as we move ahead in the weeks ahead. for taking care of patients and how your clinical workflows are going to look. So first off, I think the first is just surviving. We've all survived this deluge of emails and information that are consistently being thrown at us. So I appreciate all of your patience as workflows have changed almost on a daily basis, but I think we're gaining a little bit of stability there for many of the processes that we've rolled out. I would definitely still encourage everyone, if you have questions on a particular workflow, to go to the resource page at resource.umn.edu. It's very well kept. We were debating and considering whether we should have our own kind of site that outlines all those processes, but the resource.umn.edu page updates and has links to current workflows, and they keep that up to date. So please go to that site for additional information. We've all entered that phase of scrubbing our schedules. So learning how to enter appointment notes, which is something that we didn't know how to do before. And we've done a great job at starting to convert all these inpatient visits to phone notes, and eventually here very shortly those will be converted to virtual visits where we can use video technology. At this point, we've transitioned over 80% of our clinic visits to phone visits. So we've been very successful there. Everyone's kind of learning that process. There are tip sheets if you haven't done those or are still a little bit unsure about how those visits should go. There are tip sheets on that resource.umn.edu page, so you don't have to go back through my emails or the command center updates to grab those. Those are listed there for you. And we've all had the chance to start adjusting and learning these new phone plates and navigating this process to deliver phone-based care. We've all kind of been through changes to protocols and workflows and visitor restrictions, how those workflows are going to look at our different sites. So that's been a huge adjustment. We have moved in-person visits out of Woodbury and also out of the Voyager Clinic right now, and those are being consolidated to Explorer and Discovery. This again is being done to minimize risk to staff and preserve clinical teams as the number of patients coming into the clinic starts to decrease. And then most recently, we have adopted a policy of performing your clinic phone visits remotely, so doing those from home. And I think as we've just started launched into this week, we've seen that this presents to our workflows and current protocols and working with our clinical care teams. So I think those protocols individually within our different disciplines and specialties are something that is that we all have to develop for our small groups. Those are critical to being able to deliver those that level of care. And this is also holds true for the video visits once those are launched as well. So we've done all of these things in a matter of about 10 days. So I think it's quite astounding. And I just, again, wanted to appreciate everyone for their efforts in doing so. Okay, you can go to the next slide, please. So what to expect moving forward? We will have virtual visits using the Amwell video platform. This has been rolled out on a pilot basis through the BMT programs and solid organ transplant programs on the adult side. This is going to be the preferred method for performing new referrals and return visits. So right now you can, if you want to, use other video platforms. They are not preferred by the system. They will not be supported by our IT department. The Amwell system will be supported. So once that is launched, this is being created for us and will be integrated with Epic. And this is the system that we want to be able to use. You can use this in one of the clinic sites, or you can use this from home. So both of those options will be available. The attestation forms, everyone who is delivering care along this line needs to fill these forms out. I know there are questions about trainees and medical students and whether they should be doing those. I will find that information for you and whether they need to perform these as well. The faculty are still responsible for that patient care. So the key pieces there. If someone does not have their attestation form signed before video visits are launched or the AMWEL platform is launched, it is okay, but we want to try to get all of that done. It's preferred to have that done before we launch that. How we're going to do this, there is a training video, there are tip sheets. Everyone is going to get training on how to do these visits. It is not supposed to be hard, but it is a little tricky in terms of trying to navigate that process initially. And just like most things, after you've done it a few times, I am told that it is very easy to use. Again, you're going to want to work with your individual care teams, with your nurse coordinators and staff about how that process is going to look for you and your clinical program working remotely. Additional things that you're going to see, I think the possibility of additional consolidation of outreach clinics as in-person visits decrease. So some of our other clinics in Burnsville, Maple Grove, those are also possibilities. Right now, those are still open to in-person visits, and each of these sites is still open as a clinical site. If, for example, you did not have a personal laptop or internet connection or some equipment that was necessary for the AMWEL video platform, you can still use these clinics. They are going to be outfitted to perform the virtual video clinics. There has been discussion about drive-up care for patients that really do need eyes on them so that they did not have to come into the clinic space. This is just an idea right now. It is not being rolled out. It is something that is being talked about. So that is something that we might see in the future. You may have also seen that there is a universal outpatient policy and inpatient policy for mask use. This is still being discussed. This is still being determined how, which providers are going to have priority for this, given the limitations that we have on PPE. So I think I want you all to make sure that you're staying on top of and reading those updates so that you can know about where that mask policy is going to be rolled out first. The remote access, this was a question that came up before. Bryce asked this, and Joe, you were correct. The bandwidth issues are much improved. They have now eliminated the restrictions, the time restrictions that were previously in place. That was on an email that I sent out before. So there is no actual shifts now that people need to use, which is great news. So you can be on using the secure gateway whenever that's convenient for you or whenever you needed to use that. They are still asking that high bandwidth users, diagnostic radiology, diagnostic cardiology, hold off on that until they do a little bit more testing, but eventually that will come out as well. And then there have been also been discussions from a scheduling standpoint of consolidating virtual visits so that we get away from one in-person visit and the rest virtual visits, that we have a mechanism in place for consolidating those in-person visits to one clinic per week, and that virtual visit days would remain just those, so that there was not multiple people coming in and out of the clinic just for a single patient. So those are the brief updates. There weren't additional updates that I felt were really necessary to discuss from the call this morning. And the last thing that I just wanted to mention, if you can move the next slide forward, Emily. Again, thank you all for your hard work, professionalism, and commitment to your patient care and your colleagues. This is a time when we need to continue to be flexible, help cover for each other, help figure out how to best manage patients, discuss workflows, and how we're going to deliver care remotely. So I appreciate all of your patience and flexibility here. And I'm happy to take some additional questions. I know there's been quite a few on the chat that have come through, but I'm happy to talk about those.
There was a question specifically about continuity clinics, which is probably more appropriate for me to answer. That is something we're definitely looking into because our residents do their continuity clinics in so many different sites. We kind of need to hear from the different clinics about how they're integrating virtual visits, and I suspect a lot of those same conversations are going to be taking place for our subspecialty fellows and their continuity clinics and outpatient clinic experiences. I mean, it is incredible the pace at which we've basically completely redone our model of outpatient care. I'm sort of blown away by how much we've been able to achieve. So I'm hopeful that once people get their feet under them in the next week or two, that we'll be able to think about how to really effectively reintegrate trainees. Okay, I think we will go on and talk a little bit about what to do to take care of yourself, what to do if you're sick, and how to protect yourself in the care environment. I had put a couple of slides in here, but maybe I'll let you take the lead, Beth, and fill in if need be.
Okay, sure. I think you have first some slides about how and when to call EOHS. So let's see. Yeah, so this is correct. Basically, just remember that if you're feeling sick, if you're febrile, if you have any symptoms, that, you know, we want you to be at home and not at work at this time. We are not asking symptomatic workers to be at work, at least not yet. Symptomatic workers should be at home. So if you're symptomatic, please call EOHS. The phone number is there. I know there's been a little bit of frustration with calling EOHS lately with those nurse lines. Our new people, they're being trained, updating new protocols.
Please mute.
Wow.
Okay, can you hear me now?
Yeah,
Okay, thank you.
This is Joe. Please, everybody, keep yourself muted because we lost the last couple minutes of this. So thanks.
Okay, I think I'll start over because I couldn't even hear what I was saying. Okay, so faculty, if you are symptomatic, low-grade fevers, cough, shortness of breath, myalgias, if you're worried you have COVID, please call EOHS. They will instruct you with what to do, how to get tested. We are prioritizing testing for healthcare workers, so there should be a way for you to be directed to the correct curbside testing site if you are a symptomatic healthcare worker. There are 2 different curbside testing sites right now on the north and south sides of the metro area, so you will be instructed on where to go. So go ahead and, you know, call that, and please don't come to work. There may be a point in time as this progresses where we are having symptomatic workers come in, but that's definitely not this time. So if you're symptomatic, don't come in. For trainees, same thing goes for you. It's just that you're calling a different phone number. You are to be calling the Boynton Clinic, and they will arrange for your testing and give you instructions to stay home. So here, Dr. Borman-Shoap has the phone number there for you. So I just wanted to kind of give you an update on what you're going to be seeing coming out from the command center with regards to new infection prevention protocols. Mainly, and you've already heard us talking about it already, the universal masking. So universal masking is going to make its way to all the different units and teams and groups, but it's going to be rolled out step by step. It's not all at once. The reason is we need to watch our PPE supply, and we're kind of seeing how much more PPE this is going to be using up when we do this. So universal masking kind of refers to keeping your own mask for your own personal use all day long and having this one mask be with you each day. And then each day you get, you know, a new mask, one mask per day. This is going to be done in conjunction with our PPE conservation measure. So our PPE conservation measures have to do with uninterrupted use of face masks and N95 respirators, or careful reuse of N95s and face masks. So it's kind of a lot to explain all at once. So I think I'm not going to get into all the specifics of it. But when it's your time for your unit to go to the universal masking, you'll be notified, you'll be given specific instructions. We've identified PPE champions on all the units, so they should be available to help walk through instructions, to clarify things if it's unclear. And infection prevention is working with the PPE champions. So for example, we rolled this out in the emergency departments yesterday. So the ERs were given instructions on how to do the universal masking and the reuse or continuous use instructions. And today, right, Wednesday, March 25th, it's going to be rolling out in the ICUs. And if there's any COVID-19 cohort units, PUI units, which I think will mostly be on the adult side. Thursday, it'll be HEMOC and BMT and clinics, and then we'll go from there. Let's see. So, exposed healthcare workers. So I know there's a lot of insecurity about this right now, just because we keep changing sort of our policies as each day passes. We are completing a finalized sort of grid for what to do when we have an exposed healthcare worker. It's going to be potentially some combination between home quarantine versus having the healthcare worker return wearing a mask, as long as the healthcare worker is asymptomatic. But stay tuned for more specifics about this. I mean, we've been taking it kind of one exposure at a time. And, what happened a couple days ago, it might be different than what happens today. It basically has to do with, do we have any critical staffing shortages for that particular unit? What was the exposure? And how much risk are the patients of that exposed healthcare worker? So it's kind of a complex matrix that we're writing, and we're finalizing it. I think today, I don't know if it'll be published today or tomorrow, but that's on the top of our priority list. So you can all see what are the determining factors we're using, and what are the people on the EOHS phone calls going to be telling you when you call in that you've been exposed. So stay tuned for that. That's being finalized. There's a lot of work also being done with a testing algorithm. We're going to be coming out with sort of our advice for testing, which patients we think are most likely to be suspicious for COVID and should be tested. Again, right now, testing supplies are considered to be low, and we're still trying to conserve the the swabs in the media as well as the actual test reagents. Although I think soon we'll be able to liberalize things a little bit more. We're able to send more tests. Right now we're just sending them to MDH and Mayo, but we are starting to test on our own on-site testing, but this is still being validated, so this might take some time. So for now, we're still kind of, testing only hospitalized patients and healthcare workers. So stay tuned for this algorithm. It's being debated in the command center before we publish it. And then another thing that has been really helpful to me and wonderful is that there have been some unit-specific or specialty-specific COVID-19 protocols that I've seen coming out. So for example, we wrote one for the NICU. We wrote, in anesthesia, wrote one, some protocols that make sense and for the pediatric population. And I was able to bring them forward to the system command, and now they are getting vetted by the appropriate group at system command. There's actually this thing called care maps, where they will take the protocol and they will make sure that we have all the correct resources to be able to operationalize those plans from the system. So if you have one that you've written for your patient population, send it my way or to Sam, and we'll get it plugged into this care map thing. And they were actually really happy to receive the pediatric anesthesia one. They said, they were gonna kind of bring it to the adult side and see if they could use something similar on the adult side. So I put the contact information there again, and that's my email, my cell phone. That's the infection prevention line. Or you can always page the on-call infection preventionist if it's after hours. There's the employee health line one more time. So I think that's all I had there, but I'm sure there's questions. Oh, this was just, I copied and pasted what was on the system command email, so you probably already saw this. And it's just kind of the dates in which the universal masking will be rolled out by unit. And Dr. Neglia already mentioned that dress code.
So we're close to the end of time, but I just, if anyone sees Beth Swanson, you can't hug her or give her a high five because we're not supposed to touch each other, but many people are doing heroic amounts of work. She's towards the top of the list in my mind. So just would really encourage everyone to be patient and give us some time to sort out these things. The universal masking recommendations came out yesterday evening, and Beth was very gracious to make herself available for Grand Rounds today. So it's going to take us a day or two to really give you clear guidance about what that means. And I think it's, really a sign that the health system as a whole is really trying to think about employee safety and well-being, which is wonderful. And we just want to roll it out in a way that's judicious. And I saw lots of questions on the chat about our many healthcare workers who move sort of freely among the floors of the hospital. So just rolling it out on one unit is a little hard to understand what that looks like. So we'll work to get some more clear guidance out about that as soon as we are able.
Emily, before we go, just one thing I wanted to mention that I planned to mention at the start of this. Please, if you need letters for grants, no cost extensions, letters of recommendation for K awards, things like that, and you've got deadlines coming up and you sent them to Annie, please send it again if you haven't seen it yet. We're trying to keep up, but there's a lot of stuff that keeps rolling through. So thanks.
All right. Well, thanks everyone for taking time to be together this morning. We'll probably do some similar type of forum with updates next week. If there are specific topics or things you would like us to be sure to focus on during next week's Grand Round session, please send those ideas my way. We'll get this slide deck from today's talk sent out hopefully by later this afternoon, and get all those links that are put in there live, so you don't have to worry about cutting and pasting. We did record this as well, so should be able to get that posted for everyone. So I hope you all have a good day, be kind to one another, take good care of your patients and yourselves, and we'll see you all next week.
Thanks, Emily. Thanks, everyone.
Thank you, Emily.
Thank you.